السلام عليكم ورحمة الله.
وعليكم السلام.
Good afternoon, everyone. Today our academic activity will be mainly on cardiac imaging, starting with the basics of coronary angiography with Dr. Isa Swat. The second lecture will be on basics of echocardiogram with Dr. Saad Tabayt, and ending with role of stress echo and cardiac surgery with Dr. Al-Anwad Mhassan. We'll start the first lecture with Dr. Isa Swat. You can share your slide and start whenever you're ready, Isa.
السلام عليكم.
وعليكم السلام ورحمة الله.
Can you see the slide now?
Yes, we can see it.
Yes.
Okay. Shall we start now?
Yes, please.
Okay. Good afternoon, everyone. Today I'm going to talk about the basics of a coronary angiogram. Our objectives in this titles will be, we will talk about the types of the angiogram and coronary angiogram, then the indications, what are the contraindications, and what are the possible complications, equipment and technique, and the standard angiographic views. So the types of the coronary angiogram, either it will be diagnostic or therapeutic. Diagnostic to evaluate for the patient's conditions and coronary conditions, and therapeutic to interfere by mechanical means to treat disorders of the vascular or conduction system within the heart. The indication for the cardiac catheterization, acute MI, it's a class 1 indication, and STEMI for primary PCI, cardiogenic shock if presented with a cardiogenic shock or persistent chest pain, non-STEMI if there is previous CABG or previous PCI within the 6 months. Unstable angina, and also class 1 indication, chronic stable angina, class 1 indication if angina not controlled by medications or intolerance to medications. Abnormal stress test, also class 1 indications. Ventricular arrhythmias, class 1 indications. Left ventricular dysfunctions, class 1 indication if left ventricular dysfunction with the left ventricular ejection fraction less than 40% of unknown cause to rule out the coronary artery disease. Valvular heart disease to assess or confirm the severity of the left ventricular outlet obstructions, like for example, like in aortic stenosis or HOCM. Pre-operative coronary angiography is required prior to the heart valve surgery or in congenital heart disease to rule out any concomitant coronary anomalies or coronary disease. Contraindication to cardiac catheterization, coagulopathy, renal failure, dye allergies and infection, severe peripheral vascular disease, and in abdominal aortic aneurysm, the radial approach is preferred than the femoral approach. What are the possible complications and the risk? It's usually less than 1%, and it's really very uncommon, but it can be occurred. The major complications: death, MI, development MI, stroke, renal failure, coronary dissections, air embolism, arrhythmias. Minors, sometimes hematoma at the puncture sites, angina, vasovagal reactions, allergies to contrast agents and drugs. Equipments and techniques, we need vascular access, either femoral or radial, site cleaned, area drugged, and local anesthesia given. The needle is introduced into the artery, followed by the guide wire. Other equipment, we need the crash cart in case the patient developing any collapse or sudden cardiac wrist oxygen and suction defibrillators, and temporary pacemaker, activated clotting time ACT equipment to calculate the ACT during all the procedures. Here in this schedule, we are comparing the femoral and radial axis. The axis site bleedings in femoral 3 to 4%, while in radial ranging from 0 to 0.6%. Artery complication, femoral pseudoaneurysm and retroperitoneal bleeds, and radial rare local arteriovenous fistula, and painful hematoma irritation, pulse loss in 3 to 9%. Patient comfort acceptable in femoral and great in radial. Ambulation, the patient cannot be ambulated when we're using the femoral axis unless 2 to 4 hours after the procedures. And if we're using the radial, patient can be immobilized immediately. Extra cost, closure device. We need a closure device when we're using femoral, and in the radial we need just band. Procedure time received shorter. The femoral, it's shorter than the radial, and estimated radiation exposure, it's also shorter in the femoral than the radial. Access to the left internal memory artery, it's very easy in the femoral and difficult from right radial artery. Use of artery for CABG, not in femoral, but unknown for radial. Learning curve, it's short in femoral and longer in radial. More than 8 French guide catheters, no problems, can be used in femoral. The maximum to be used in radial is 7 French in men. And peripheral vascular disease in obese, problematic in the femoral because the fat, we cannot use it, and no problem in the radial. And this articles, they are comparing the transradial versus transfemoral artery approach for coronary angiogram and PCI in extremely obese person. And they are evaluating the safety and efficacy of the transradial versus transfemoral axis in patients who have body mass index more than 40 kg per square meters. The result was that the radial axis procedure were associated with an increase in procedure time and patient radiation dose, but transfemoral, in conclusion, the transfemoral axis for coronary angiogram and PCI was associated with more bleeding and axis complication in those patients when compared with transradial approach. This is this slide showing the Slinger technique when we inserted during the coronary angiogram. First, we are inserting the needle with a cannula to the arteries. Then we are, after the blood is coming out, we are removing the cannula and removing the needle and leaving the cannula inside. Then we inserted the guide wire through the cannula, and then we removed the cannula, keeping the catheter inside the arteries, and then the guide wire removed, leaving the catheter inside the guide wire, as we say. When the guide wire is in the vessels, needle is removed. Under fluoro, the catheter is then advanced and the guide wire is removed. After engaging into the coronary ostium, contrast injected to confirm the position of the catheter. Catheter selection of the catheter, the right catheter is important and is dependent on the flow. Access sites, which site you are using, either radial or femoral, aortic width, and the coronary ostial location, high or low, or anterior versus posterior, and coronary ostial orientation. A standard catheter for routine coronary angiogram, it's Judkins, right size 4, and Judkins left size 4. Basic coronary coronary anatomy, I will talk about it before we talk about the views. The left main coronary arteries, the left, it's originated from the left coronary cusp and bifurcate to give rise to the left anterior descending and the left circumflex arteries. Left anterior descending artery provide blood supply to the anterior wall of the left ventricle and 2/3 of the anterior septum. It's divided to 3 parts: the proximal part from the ostium to the first diagonal branch, and then the mid portion from the first diagonal branch to the second diagonal branch, and distal from the second diagonal branch to the end of the LAD. Left circumflex artery, it's the left, crosses around the left ventricular groove and give rise to multiple obtuse marginal branches. It's divided also to 3 portions: proximal ostium to the first major obtuse marginal branch, and a second mid portion from the first obtuse marginal to second obtuse marginal, and the third with the distal portion, it's from the second obtuse marginal to the end. The right coronary arteries arises from the right coronary cusps and follows the right AV grooves. Proximal, it's divided the proximal to ostium to the first main RV branch, and the mid from the first RV branch to the acute marginal branch, and distal to acute margin to the crux. Here we see the dominance. Most of the hearts are 80 to 85% are right dominant, and where the BDA is supplied by the right coronary artery, the remaining 15 to 20% of the heart are roughly equally divided between the left dominant and co-dominant. The left dominant, sometimes it's coming the BDA, it's coming from the LAD or from the left circumflex. A standard angiographic fuse, an easy way to identify the tomographic fuse to use the anatomical landmark. Catheter is in the descending aorta, spine, and the diaphragm, and the roof rules are the right anterior oblique versus left anterior oblique. If the spine and the catheter are to the right of the image, it is left anterior oblique, and vice versa. If central, it's likely it's posterior view. Another fuse is cranial versus caudal. If the diaphragm shows can be seen on the image, it's likely cranial view. If not, it's caudal. The cranial angulation is ideal for visualization distal portion of the vessel, and the caudal angulation is ideal for visualization of the proximal portion of the vessels. The right coronary artery is typically imaged into view. We can see it anterior views. The first view, it's left anterior oblique views, and best for demonstrating the ostium of the RCA and mid portion of the RCA, and the bifurcation of posterolateral branch and the BDA. Second view, it's right anterior oblique view, best to demonstrate the mid portion of the RCA and extent of the BDA. Ostium is not visualized in this views. The left coronary artery is typically imaged in 5 views. The right anterior oblique caudal view is best for distal left main stem and proximal segment of LAD and circumflex artery and its branches. Second view for the left coronary artery is the right anterior oblique cranial views is best for the LAD and diagonal branches. As we see here, the LAD and this, the diagonal, the first diagonal, second diagonal, and third diagonal. The third view, it's the left anterior oblique 90 degrees straight lateral views, and it shows the mid LAD and the circumflex artery. The fourth view, left anterior oblique cranial views, best demonstrating ostium of the left main, the ostium of the left main, and the origin of the diagonals from the LAD, as we see in these views. The fifth view is the left anterior oblique view, caudal view, and we call it also spider view. It's best to see the distal left main and proximal LAD and proximal circumflex artery. Angiogram interpretation, a systemic interpretation of a coronary angiogram would involve evaluation of the extent and the severity of a coronary calcification just prior to or soon after contrast ossification. Lesion quantification in at least 3 orthogonal views, as we are seeing the severity, the calcification, presence of the ulceration, thrombus, degrees of tortuosity, lesions, calcification, and reference fissile size. Analysis of the coronary angiogram, we are seeing the degree of the stenosis. If it's less than 25%, it's considered to be normal. It's considered to be low grade from 25 to 49, intermediate grade from 50 to 70. 4% and high grade from 75 to 90, and subtotal from 91 to 99, and total occlusion in 100. TIMI flow grades, it's we are using thrombolysis in myocardial infarction. TIMI flow grade has been used to assess the degrees of the restored perfusion achieved after thrombolysis or angioplasty in patients with acute myocardial infarction. A grade 3 complete reperfusion after the thrombolysis is normal flow, which fills the distal coronary bed completely. A grade 2 partial reperfusion, delayed or sluggish antegrade flow with complete filling of the distal territory. A grade 1 penetration with minimal perfusion, a small amount of contrast flows through the stenosis but fail to fully ossify the artery beyond. Grade 0, there is no perfusion, complete obstructions. Fractional flow reserve is calculated by the ratio of the coronary pressure distal to the lesion compared to pressure proximal to the lesion. And FFR of 1 is widely accepted as normal. FFR lower than 0.75 to 80 or 0.80 is generally considered to be associated with MI. This article, it's showing that the FFR versus angiograph for guiding BCI, it shows that guided angiographic alone with or guided by FFR measurements in addition with angiography, patient assigned to angiography BCI underwent stenting of all indicated lesion, whereas those assigned with BCI with FFR stenting of indicated lesion only if FFR was 0.80 or less. In conclusion, routine measurement of FFR in patients with multifaceted coronary artery disease who are undergoing BCI with drug-eluting stents significantly reduces the rate of composite endpoints of death and non-fatal MI and repeat revascularization at 1 year. In this slide, we are seeing the syntax score we calculated. This is purely an anatomic score of the extent of the coronary artery disease, more than 50% in patient. Each lesion is assigned a numerical number, and then summation of all lesion score for a patient is calculated to come up with a final numerical syntax score. Patient divided to 3 groups: low less than 22, intermediate to 23 to 32, and high more than 32. In this syntax score, we are seeing the number and the location of the lesion, assessing the left main, 3 fissures, if there is any total occlusion, tortuosity, bifurcation, thrombus, and calcification and dominance. And the left pictures, we are seeing the dominance. If it's if the PDA, it's coming from the right. We call this right dominance, and if the PDA it's coming from the left, it's left dominance. Analysis of the coronary angiogram, other methods, we have IVUS, intravascular ultrasound, and OCT, the optical coherence tomography. These two technologies are analogs in that they send out energy waves. OCT uses light and IVUS uses sound waves into the vessels walls, and that energy is sent back to the catheter to reconstruct an image. It allows direct image of the luminal diameters and vessel wall, giving a visual assessment of atheroma or any calcification inside the vessel wall. It's useful in patients with equivocal stenosis and vessel with marked endoluminal calcifications. Coronary aneurysm vessel diameter more than 1.5 and comparing with to the neighboring segments, the incidence it's ranging from 0.15 to 4.9% and very rare in left main coronary artery. The etiology mainly atherosclerosis. Other causes may be including PCI, inflammatory disease, or trauma. The treatment is depending on the patient conditions. It's including either observation or taking the patient for the surgery or putting occlusive coiling or therapeutic coiling or catheter stent. Anomalous origin of the ACA from the right sinus of the Valsalva. It's very rare, and the course relatively to the great vessels is variable and must be defined. If inter-arterial surgical therapy is warranted. As we see here, it's the left coronary artery. It's originated from the right coronary cusp, and it's running between the aorta and the pulmonary arteries, and this is in case the risk of sudden death and urgent surgery. Then the second, in the right side, the left coronary artery is originating, and it's taking the retro aortic course, and usually in this condition, the prognosis is very benign. Anomalous origin of the RCA from the left coronary artery, it's very rare and arises anterior to the origin of the LCA. RCA runs in the interarterial course and usually benign. Aorta root angiography, normal means backwards flow of the contrast media into the left ventricle during injection. Atrial oximetry and blood pressure within the aorta are measured, then advance into the left ventricle. Right ventriculography, we are using the right ventriculography to evaluate the cardiac shunt, evaluation of the valvular heart disease, and investigation for pulmonary hypertension. Left ventriculography provides information septal integrity and pressure measurements are made when systolic in the left ventricle does not match the systolic in aorta, could mean that there is aortic stenosis. That's the end of my presentation. Thank you for listening. Any question?
Thank you, Isa, for your presentation. It summarized well the basics of coronary angiography, but it would be great if you could have added some examples of our daily practice that we see in the cath lab, cases that we can discuss, lesion that we can describe, and so we can make it more interactive. But overall, good presentation. Thank you, Isa. Any question or comment from the group?
You're welcome.
Since there is no questions, we can have a 10-minute break and then we'll come back at 1:40 for the next lecture with Dr. Asad.
دكتور خالد.
Yes.
Dr. May will join us at 2 p.m. She cannot join before that. Is that okay?
You're expecting your talk to finish in 1 hour or less?
My talk, maximum 40 minutes.
Okay, since we are expecting our guest consultant, Dr. May, to join us at 2 p.m., we'll have a 20-minute break and then we'll join back at 2 p.m. to resume our academic activity for today.
دكتورة مي. Dr. Mai, can you test your mic now? If you can hear me.
Yes, we can hear you.
I think Dr. Mai, she's facing a technical problem with her mic. Just make sure if she's can use it and hear me.
I unmuted. You can hear me. So how I mute again?
يلا تمام دكتورة، يعطيك العافية. Assalamu alaikum. Good afternoon, everyone. First of all, I would like to welcome Dr. Maya Shahid, cardiology consultant, echocardiographer. It's a pleasure to have you, Dr. May, in our academic activity, and inshallah we will have a benefit from this talk. So today, inshallah, we're going to talk about echocardiography for cardiac surgeon specifically. These are our outlines. We will start with introduction, then we will review some principles and basics. Moving on to modalities or different modalities of Doppler echocardiography, and we will discuss some specific cardiac diseases, and we will have a small talk about TEE or transesophageal echo. So the main objective for this talk is to have a clear background and make a strong principles for understanding the echocardiography. As you know, echocardiography has become the major imaging and diagnostic modality of cardiac diseases. So all cardiac specialists, cardiologists, and surgeons need to understand basic principles, approaches, indications, and even expected results in order to make appropriate interpretations. So the present summary that we will talk about it of Doppler echocardiogram principles will provide basics knowledge for major cardiac conditions, mostly acquired, to ensure a proper functioning of the team, echocardiographer and cardiac surgeon. So the origin of clinical echo dates back to 1950, and it's credited to Karl Hertz and Edler. Those people, they have invented this echo during assessing patients with mitral stenosis using the time, motion, or M-mode approach, identified a moving signal with cardiac motion. Then after this technique was used for the evaluation of mitral stenosis. And their first paper entitled The Use of Ultrasonic Reflectoscope for the Continuous Recording of the Movement of the Heart Wall was in 1954. So how does it work? Echo uses high frequency from 2 to 7.5 to image the heart and measure blood flow velocity. Imaging is produced by the reflection of ultrasound. This ultrasound is produced by crystals contained in the transducer head, as you see in the picture. It will reflect on the cardiac walls, and to achieve reflection, ultrasound first has to penetrate body tissues. So this penetration is excellent in water, which is the blood, and it's medium in fat, and it's minimal through the air and bones, because they are strong reflectors that no energy is left to progress within the cardiac tissue. So echocardiographers use windows between the ribs, sternum, and the lungs, such as the parasternal, apical, subcostal, suprasternal, transesophageal, or intracardiac, to ensure good penetration of the ultrasound. Now, the ultrasonic imaging is not a photography, actually, but it's images of the cardiac structures that is generated by the concept of the scanner converter. What do we mean by that? The exact mechanism depends on the time, counting the time between the emission of the ultrasound and the return of the reflected wave to the same crystal, and it will calculate the distance from the transducer to the reflective structure in base of assuming a constant speed of ultrasonic progression in blood. And the single crystal imaging is M-mode, whereas two-dimension is produced by series of crystals, and we have the newly developed three-dimensional imaging. So in intracardiac velocity is measured based on the principle of the Doppler effect. What do I mean by that? The moving target changes the wavelength of reflected sound. So the frequency change magnitude is proportional to the velocity of the moving target, and its direction indicates the direction of the moving target toward or away from the transducer. And we have two types of Doppler ultrasound that can be used. We have pulse velocity and is measured through a small gate. So it has one crystal, and it's enable or cannot measure high velocity and range resolution. And we have the continuous wave Doppler, allows measurement of high velocity or gradients. So the kinetic energy, which is the velocity, is maximal at the stenotic orifice, while the potential, which is the pressure, is lowest. After the orifice, when the blood decelerates, the pressure will increase. That means slightly downstream from the orifice where the catheters are usually placed, pressure is higher and the gradient lower than or lower at the bulb orifice itself. This phenomena is usually minimal but can clinically relevant with some prosthesis or small aorta. The principle or the term of color flow with echo, it's based on the velocity measurement by Doppler and is coded as yellow for the flow toward the transducer and blue away, as it's shown in the picture. Now, when the maximum blue color is reached, the color, it switched to yellow for higher velocity and so on. It will become more yellow at the higher velocity, and this will give the effect of the mosaic appearance. This is the mosaic appearance of the velocity jets at the high velocity. Now we have finished with the basic principles or terms that is used in echo. Any question or comment, or it's clear to move on? Dr. May, would you like to comment on this part or at the end?
You can hear me now?
Yes, it's clear.
Okay. Actually, I think the most important thing that everybody should know about this part is that the crystals are arranged in the transducer in certain ways so that when they get electricity, they vibrate, and according to their number, their sizes, how they are organized, they will give the high frequency ultrasound waves. So this is how it happens. And these waves go into the tissue to be reflected by different surfaces, because once they hit the first surface, part has to go back and part has to go in to hit the second surface, to hit the third surface, until the whatever passing to the further thing is becoming too weak. And at every level, part of the ultrasound will go back. And as you said, by the time and how much it takes to go and come back, we know the depth of it. And since we send multiple such waves, we can have different dots for every surface. And then these are added together to give us a complete surface. So remember, it is multiple waves that multiple lines of ultrasound that we send to give us the picture. And we have to be perpendicular to the structure to give us a good picture. As to the flow, which you explained very nicely, we have to be parallel, because there is a certain formula which is very important called the Doppler formula that insists that the angle should be as near as possible to zero, because we measure the cosine of this angle, and cosine 0 is 1. So to get good 2D, we need to be perpendicular. To get Doppler, we have to be parallel. Otherwise, you explained everything nicely.
Okay, thank you, Doctora. Now we can end this part by have a general idea or overview of the different views that can we get by the TTE or transthoracic. I have a very nice video to share with you. Just a minute, please. And tell me, please, if it's not clear, either the picture or the sound, just let me know.
Probe of choice for this examination is the cardiac probe, aka the phased array probe. This probe is great for fitting in between the rib spaces. If your machine does not have this probe, the curvilinear probe can be used, but really the preferred probe is the phased array probe. First, we need to talk about probe positioning. You will use the standard mode where the indicator is on the left of the screen for most scans that are non-cardiac. In this convention, the probe marker will either be to the patient's right side or to the patient's head. To get a cross-section of the heart, however, you need to imagine the heart as an upside-down cone. In standard mode, a cross-sectional view or short axis view of the heart will have the probe marker pointing to the patient's right hip, and in long axis view to the patient's left hip. As an example, this is a parasternal long axis view of the heart. We are in standard mode, shown by the red arrow on the left of the screen. The probe marker on the body is facing to the patient's left hip. Contrast standard mode with cardiac mode. Notice the indicator is on the right of the screen, shown by the red arrow. In this view, again, imagining the heart as an upside-down cone, the long axis view will have the probe indicator pointing to the patient's right shoulder and in short axis orientation to the patient's left shoulder. This is opposite of standard mode, but so is the indicator on the screen opposite of standard mode. Therefore, the image acquired will be the same. Basically, if you flip the indicator, then you need to also flip the probe. This is a parasternal long axis view of the heart. Probe marker is facing to the patient's right shoulder, and we are in cardiac mode because the indicator on the screen is on the right side. Remember that the left ventricle should always be on the left of the screen for parasternal long axis. We will talk about that again. So here the image looks different. It is actually flipped. Remember when I said that the LV should be on the left of the screen? Well, here it's on the right. Why is this image flipped? First, see that the indicator on the screen is on the right, which tells you that you are in cardiac mode. Then, see where the probe marker is facing, and in this case, it is facing down to the patient's left hip, the orientation in standard mode, not cardiac mode. Remember, in cardiac mode for parasternal long axis, probe indicator should point to the right shoulder. This image also looks different. Again, it is flipped. Why is it flipped? First, see that the indicator on the screen is on the left, which tells you that you are in standard mode. Then see where the probe marker is facing, and in this case, it is facing to the patient's right shoulder, the orientation in cardiac mode, not standard mode. Remember, in standard mode, probe indicator should point to the left hip. So, to summarize, in cardiac mode, the indicator on the screen should be on the right side, and the probe marker should be facing the right shoulder. The LV should be on the left of the screen. The heart forward and closer to the chest surface, which could help in acquiring your image. Have them lay on their left side. It may help to ask the patient to a long axis view. You can remember it by the 3 on the patient's body should be facing the right shoulder. Start by placing the probe at the nipple line or fourth intercostal space, or in women, the inframammary line, right next to the sternum. Keep the probe perpendicular to the skin and hug the sternum as you go up and down the chest, searching for the best window. So, I told you I would give you an easy way to remember the parasternal long axis view. You can remember it by the 3 L's to success. The parasternal long axis should have the left ventricle on the left side of the screen. So for a visual, here's what we're looking at. For the parasternal long axis view, make sure the left ventricle is on the left of the screen. Before we go identifying what we see on the image, it may be helpful to see a schematic representation on the ultrasound image. Toward the top of the screen, we will see the right ventricle, with the left ventricle beneath or deeper to it, and the interventricular septum in between. In the left ventricle, you can see the mitral valve and sometimes the papillary muscles. To the right of the mitral valves, you will see the left atrium. In this image, you can also see the aortic valves and the aortic outflow tract. Going back to the ultrasound image, if we again imagine the heart as a cone, the apex is at the upper left of the screen, with the base towards the lower right. Anteriorly is at the top of the screen, which makes sense because that is where you physically have the probe, on the chest. And deeper or towards the bottom of the image is the posterior portion of the heart. The items to identify in the parasternal long axis view are the left ventricle, the right ventricle, the aortic valve and the mitral valve, the left atrium, the interventricular septum, the descending aorta, which will be important for distinguishing between a pericardial effusion and a pleural effusion. We'll talk about that later. The aortic outflow tract, and the pericardium. The parasternal long axis view is great for estimating ejection fraction. There are a few studies that show that eyeballing the ejection fraction by looking at the squeeze of the heart and how closely the anterior mitral valve leaflet gets to the interventricular septum is a good estimate of the gold standard cardiology method of evaluating the EF. Additionally, it is much faster and can easily be done in the emergency setting. In this ultrasound image, you can see that the anterior mitral valve leaflet is slapping up against the interventricular septum. You can also see that there is good squeeze of the left ventricle and that the ventricular walls are almost touching with each contraction. This is indicative of a normal ejection fraction of greater than 50%. In this ultrasound image, the anterior mitral valve leaflet does not quite make it to the interventricular septum. Additionally, the squeeze of the ventricles just isn't as good as the last image. This EF is consistent with moderately depressed at 30 to 50%. How do we know it is not severely depressed? Look at the next image. In this image, there's very little motion of the mitral valve leaflets and hardly any squeeze of the ventricles at all. This is a sick heart with an ejection fraction of probably less than 30. If you want to quantitatively measure the ejection fraction and not exactly eyeball it, you can do so using EPSS, or E-point septal separation. This is a heart in the parasternal long axis view. If we want to use EPSS, we just throw down an M-mode spike at the tip of the anterior mitral valve leaflet. You can freeze the image and this is what you will see. The thicker white line represents the interventricular septum, and the squiggly wavy lines beneath that represents the motion of the anterior mitral valve leaflet. I don't know if you noticed, but the anterior mitral valve leaflet slaps twice on the interventricular septum in a normal heart. The E represents the passive filling of the ventricles, and A represents the atrial contraction. The distance between the IVS and the squiggly lines show just how close the anterior mitral valve leaflet gets to the interventricular septum. A distance of less than 7 millimeters is considered normal, and greater than 10 is considered LV dysfunction or reduced EF. 7 to 10 is sort of a gray area and needs to be taken into context. Notice, this distance is greater than 10 millimeters and is consistent with CHF. This is another example of reduced ejection fraction. CHF is not the only way that your patient can end up with a reduced EF. If your patient has aortic regurgitation, the backflow of blood will inhibit the anterior mitral valve leaflet from opening fully. This will make your EPSS larger even though there is no CHF. Or, if your patient has mitral stenosis, the poor excursion of the mitral valve leaflets will give you a large EPSS, falsely predicting cardiac ejection fraction. Now, I mentioned earlier that in this image we are more inferior or downward flow of the RV. This can be too large. Now we're going to talk about the parasternal short axis. From the parasternal long axis view, rotate the probe 90 degrees clockwise towards the patient's left shoulder. Then fan towards the apex and up towards the base. Fanning up towards the base of the heart to the patient's head will get you more of the mitral valve, even the aortic valve in view. In this image, we are more inferior or towards the apex in the mid-papillary view. The circle in the middle is the left ventricle. On the other side of the IVS is the right ventricle. The arrows are pointing to the papillary muscles and the mitral valve. Fanning superior to the patient's head, you can see the mitral valve leaflets and the fish mouth view. Fanning even more superiorly, and you can see the aortic valve, called the Mercedes-Benz sign. Here's a schematic that will help identify the images in the parasternal long axis view with the aortic valve in view. Most anteriorly is the right ventricle with the RA feeding through the tricuspid valve. The tricuspid aortic valve is right in the middle. The left atrium is the deepest structure feeding down into the screen out of plane of the probe. The LA is the deepest structure. So in review, more inferiorly or towards the apex is the mid-papillary view. Fanning up towards the head, you can see the fish-mouthed mitral valve. Most superiorly, you can begin to see the aortic valve. You can also assess for right ventricular strain in the parasternal short axis view. Here we see an enlarged RV and septal bowing showing something called the D sign, where the pressure, you see the chamber size getting smaller. Fan probe indicators pointing toward during systole to actually cause the demonstrating the D sign. Probe indicators pointing towards the patient's left axilla, and from the parasternal short.
So it seems to be long video, but I'm concentrating on the fuse because it's showing the fuse in very nice way and simple.
Axis view, slide down towards the apex until you see the chamber size getting smaller and smaller. Then, when you get to the apex, or when you see the chamber size getting smaller, fan up towards the patient's head. The probe at this point should be at the point of maximal impulse. The bottom right image displays the LA and the LV on the right of the screen, and the RV and the RA are on the left of the screen. As a general rule, taking the ventricles as one, the LV should take up about 2/3 of the total, and the RV 1/3 of the total. Consider PE or another acute event causing pulmonary hypertension if the RV is greater than the size of the LV. You can also assess for pericardial effusion in this view, as shown in the image at the top left. The fourth and final window of transthoracic echocardiography is the subxiphoid view. With the patient's knees bent, place the probe in the subxiphoid region. Make sure the indicator on the probe still points to the patient's left side. Assume an overhand grip on the probe. This will help you get more level and parallel with the skin, and will allow you to visualize the heart. Start on the patient's right. Locate the liver and sweep to the patient's left, using the liver as an acoustic window. Basically, acoustic window just means using an organ that doesn't contain gas and allows sound waves to travel through. In the subxiphoid region, bowel gas can sometimes mess up your image, so using the liver as an acoustic window will help avoid this. You can have the patient take a deep breath to help bring the heart into view. So here, the liver is being used as an acoustic window. Remember, the RV is closest thing to the liver. In this view, you can see the LV, the LA, the RV, the RA, mitral valve and tricuspid valve, and the pericardium. This is a video clip of the same thing. Up here.
So this is an overview of the fuse using the transthoracic echo. Any comment, Dr. May, or addition?
Actually, you can hear me?
Yes, Doctor, clear.
Okay. I think the most important thing, I have a feeling he's not a cardiology initially. He must have been a abdominal or something like this, because his first thing is really confusing. All you have to remember is that there are 4 windows. He missed the suprasternal, but there are 4 windows where we put our transducer, where there is no gas and no bone. As you said, ultrasound hates gas and bone. So it hates the lung and it hates the bone of the front of the chest. And we try to get away from them. And then we get pictures from every one of these windows that can help us make in our brain a visual sort of 3-dimensional view of the heart. That's why we move between the 4 windows, so that we look at every window and we look at certain parts of the heart, and then we add it all in our brain. Luckily now we have the 3D. The 3D is going to give us like a pyramid, and it is 3-dimensional. So that's all as people who are not doing it, you really don't need to know all these details, be on the right, be on the left, marker to the right, marker on the left. This is the job of the echo people. But there's no doubt that there are certain things that are important for you. For example, if you are carrying the pocket echo machine, you really need to know how to put your transducer with the marker to the left, and then look at the left ventricle in the short axis. But these are limited things that you gain with experience. Thank you very much, Suha.
Thank you, Doctora. So we can move on. Now we will talk about the modalities of Doppler echocardiography. As we have multiple modalities, respond to different clinical questions that should be clearly defined by the managing team for having an optimal differentiation or optimal diagnosis. So, starting by the transthoracic echocardiography, as you know, this is completely non-invasive and safe modality. First, we have the standard TTE, which includes the 2D morphological assessment, and we have 2D derived M-mode measurement of the cardiac dimensions, and we have the pulse style wave and the continuous wave, as we have talked about it before. Also, we can assess the advanced hemodynamics, which is necessary or indicated in patients with valve heart disease or poor hemodynamics. And as it's shown in this picture in the corner, which I got it from this article, and the main are the stroke volume, cardiac output, index, and we have the flow across an orifice, and it's the product of cross-sectional area. Also, we have the TTE with respirometer. This is mainly used when we have or we are comparing or to differentiate between the pericardial and restrictive myocardial diseases that are suspected in our patients. And it's, you know, just related and correlate with the inspiration and expiration. Stress echo with TTE used much more than TEE and mostly in myocardial diseases. And the goals of using the stress echo, first to diagnose the ischemia, depending on the maximum stress, and to assess the myocardial viability in patients with reduced ejection fraction by low dose dobutamine. The next lecture will concentrate more on stress echo by Dr. Al-Anoud, inshallah, with more details. However, still with all these positive points, the TTE has a drawback or pitfalls in regard of the hemodynamic effect of conscious sedation or anesthesia that affect the evaluation of cardiac disease, particularly the valve regurgitation and the limited ability to modify the position of the transducer. So the assessment is usually or sometimes limited, and this is considered a limitation for using this diagnostic tool. And lastly, we may lose the image quality in distant field, so that the LV apical abnormalities are most often better defined by TTE. Coming to the specific cardiac disease, we will start or have a general overview of the valve diseases, then the coronary disease. So starting by the mitral valve, in different stages, pre-operative assessment of the mitral valve regurg regarding the etiology and mechanism to know the mechanism using the echo. As you know, the organic mitral valve regurg results from diseases affecting the valve leaflets or supporting the structures, resulting in improper cooptation. So the echo usually determine the organic mitral valve regurg etiology. So the most frequent of which is causing the regurg is degenerative with myxomatous mitral valve disease with prolapse or fibroelastic degeneration of the mitral leaflets. This is generally associated with a primary filial leaflet or annular calcification. So in this picture on the left, the patient has a filial segment of the posterior leaflet with marked gap between the anterior and posterior leaflet during systole and tip of the posterior leaflet in the left atrium. The next picture on the right, the simple mitral valve prolapse shows posterior movement of the leaflet in the left atrium, but no gap between the leaflets, and the tip of the posterior leaflet remains in the left ventricle in systole. We can also assess the valve dysfunction severity. So the Keller Doppler alerts to mitral valve regurg presence, but estimation of mitral valve or mitral regurgitation severity should rely on comprehensive assessment based on American Society of Echocardiography criteria and not just on the jet extent in the left atrium, because the jet constrains by the left atrium wall, and this makes measurement unreliable sometimes. So eccentric jet as it's shown of mitral regurg seen a thin layer of color with appearing as a mosaic color in LA, and here central jet of mitral regurg seen a large area of mosaic flow in the LA. This is a picture of continuous wave Doppler of mitral regurg jets. The jet is holosystolic, but the peak velocity is reached during the first half of systole. This is suggesting is existence of large volume on the LA pressure that will lead to a rapid equalization of pressure between the ventricle and atrium. And this type of jet seen in acute MR. Sorry. In the next picture, on the right, the jet is also holosystolic, but the peak velocity is reached in mid to late systole. This type of jet is often seen in patients with chronic MR. So still we are in the preoperative assessment, how to identify or assess the prognostic indicators. By assessing the LV is usually performed by measuring the LV diameters and ejection fraction. So in the diastolic diameter greater than or equal to 40 to 45 and ejection fraction less than 60%, these markers of poor outcome. And these characteristics are considered class 1 indications for surgery. Now, also still with prognostic indicators, LA diameter is greater than or equal to 50, associated with high risk of subsequent atrial fibrillation under medical management, and it should alert early need for the surgery. For the pulmonary hypertension, this is considered as a marker of poorly tolerated mitral regurg, although it's associated to subsequent prognosis or association, it's not that much clear and it's not certain. For the intraoperative assessment of the mitral valve regurg, before the cardiopulmonary bypass, the TEE confirms the mitral lesions, but also identifies associated conditions that may benefit from the surgical therapy, such as PFO, appendage, or LA thrombus. Post-operative, you know, as the most common immediate complication after mitral valve replacement are the periprosthetic leak and mechanical dysfunction of the prosthesis. This is due to the interaction of the tissue remnants with the mobile elements of the prosthesis. And in contrast to transthoracic, the transesophageal echo has no shadowing from the mitral prosthesis, so the periprosthetic mitral regale should be carefully sought after bypass, and those clinically relevant distinguished from minor paravalvular or intravalvular leaks that are often seen. Post-operative, we need to evaluate the mitral valve as follow-up for the valvular result at pre-discharge and yearly and 3 to 6 months post-operatively. This is most commonly in our practice. And the mitral regurg recurrence rate after valve repair is range from 5 to 10% at 10 years. For the quantitative Doppler assessment of mitral valve regurgitation, the picture on the left, it measures the mitral stroke volume, and right side measures the aortic stroke volume with these numbers. So the regurgitant volume is calculated as the difference between the mitral and aortic stroke volume. For the stenosis, mitral valve stenosis, the classical mitral valve stenosis is caused by rheumatic disease, and the features are immobile posterior leaflet, fused commissures with reduced orifice area, and hockey stick deformation of the anterior leaflet in the diastole. As this picture is showing, it's a parasternal long axis view of patient with mitral stenosis. As you can see, there is thickening and hockey stick deformation of the anterior leaflet of the mitral valve and the protrusion of the posterior leaflet. And also we have normal left ventricle contrasting with the enlarged left atrium and right ventricle. The gradient in the mitral valve stenosis that is measured is the mean gradient, which is affected by severity of the stenosis. And it's increased by tachycardia and amplified transvalvular flow in cases such as anemia, pregnancy, hyperthyroidism, or if it's associated with mitral regurg. And it's decreased by bradycardia and low cardiac output. So mild mitral stenosis associated with arresting mean diastolic Doppler, which is measured by the continuous wave Doppler. And as you know, it's ranging from mild to moderate. If it's less than or equal to 5, or 5 to 10, this is moderate, or more than 10, this is severe. Also, the normal mitral valve area is 4 to 6, and the guidelines for mitral valve stenosis suggest the threshold of 2 centimeters square for mild, and 1.5 for moderate, and 1 for severe mitral stenosis. And most of the patients, however, are undergoing intervention in the range of 1 to 2 or 1.2 and are symptomatic. So, as you see in this picture, the continuous wave Doppler recording of the mitral gradient in patients with severe mitral stenosis, the high velocity greater than or equal to 2, with mean gradient greater than 13, the flat slope of deceleration of the early diastolic velocity consistent with severe mitral valve stenosis. This is another picture of continuous wave Doppler in the same patient after commissurotomy. The mean gradient is now low with rapid deceleration of early diastolic velocity consistent with mild mitral stenosis. Moving to the aortic diseases, starting by the aortic stenosis. So the most common causes are the degenerative diseases, irrespective of the number of the cusps of the valve. However, the recent data showing the atherosclerotic mechanism of aortic stenosis are based on the cholesterol deposition, as you know, and lipid oxidation, but bicuspid valve tend to calcify more frequently than the tricuspid valve for unknown reasons, at least till now. Rheumatic aortic stenosis is now rare and characterized by commissural fusion, whereas the commissures are open in the degenerative diseases. So this is two-dimensional echocardiography of patient with aortic stenosis. As it's shown by the arrows, the aortic valve is heavily calcified. It's showing a dense nodule. And this is continuous wave Doppler obtained from the parasternal window in a patient with severe aortic stenosis. It's showing that the peak velocity is greater than 4 and the mean gradient is 48. Now, for the aortic valve, moving to the aortic regurgitation, the rheumatic aortic valve is recognized by the retraction of the leaflet, which will leave a central regurgitant orifice and is rarely repairable. Endocarditis is recognized by echo when there is a vegetation. And in those cases may require transesophageal echo. So this is a picture or image showing aortic valve in patient with endocarditis aortic regurgitation. And the arrow, this one, the long one, it's showing the vegetation, whereas the arrow in the front of it showing a perforation of the non-coronary cusp. Tricusp valve stenosis, in case of stenosis, is mostly caused by rheumatic, associated with mitral, mostly associated with mitral stenosis, and it's rarely to have pure tricusp valve stenosis. It's difficult to diagnose as there are no absolute morphological criteria and compared to other valves that we have discussed before. So the essential diagnostic step in those cases is to perform a continuous wave Doppler examination of the tricusp valve when morphology is unusual and mean gradients greater than or equal to 5 are significant for tricusp valve. Also, the degree of inferior vena cava dilatation, it will reflect the hemodynamic consequences of this stenosis. Pulmonary valve, the valve morphology is difficult to analyze and it usually requires unusual fuse, elongating the subvalvular, valvular, and supravalvular region. So the thickening can be observed and rarely in cases of prolapse, retraction, or vegetation. So morphologically, pulmonary annulus can be constricted in carcinoid disease in association with intrinsic valve thickening. We have finished with the valve diseases and we will move on to coronary diseases. But before, Dr. May, you have an addition or comment on the previous part?
Let me comment after you finish the coronary artery, because I think these two are the most important things, and then I'll comment at this, on them together, if you don't mind.
Sure, Doctora. However, for the coronary artery diseases, I have another short video. It's 7 minutes showing the distribution and perfusion of the coronaries and how can we correlate this with the echo findings and interpret.
Which is the hallmark for the diagnosis of coronary artery disease, is probably the most difficult thing in echocardiography. However, the good news is there's a lot of patients you can practice in because we see them very often. But we'll not only talk about regional wall motion abnormalities, we'll also talk about other things which are equally important, such as wall thickness or the echogenicity of the myocardium. So this will be the topics of this forthcoming chapter. Before we look at actual regional wall motion abnormalities and before we look at examples, we first have to discuss which segments we can find and how we can explain to someone else where we see a wall motion abnormality. First, we divide the ventricle into 3 different segments with respect to the long axis. We can delineate the basal segments, the midventricular segments, and the apical segments. But remember, since the true apex is probably further up here because we have foreshortening, we need to also divide the mid from the apical segment further up towards the apex. Here are now the short axis views, the corresponding short axis views at the base, at the mid, and at the apical level. Here too, we divide the myocardium into different segments. The first segment, which is fairly easy to describe, is the septum, because it's defined as the myocardium which lies between the right and the left ventricle. The septum itself is divided into the anterior septum and the inferior septum. Right adjacent to the anterior septum we have the anterior wall, followed by the lateral or anterolateral wall, the inferior lateral or posterolateral wall, the inferior wall, and then again the inferior septum. The same segmentation is performed also at the mid-level. At the apex, however, we only have 4 segments. We have the anterior wall, the lateral wall, the inferior wall, and the septum. The lateral region is now a combination of the posterolateral and the lateral region, and the septum is a combination of the anterior and the inferior septum. In other words, we only have 1 septal segment opposed to 2. So how does this now translate to the apical views? Well, we have a segmentation into the basal, the mid, and the apical segments, and thereby we can describe different regions of the myocardium. This is the 4-chamber view, so what we see here is the septum. Therefore, this must be the basal septum. What we see in the 4-chamber view is usually the inferior portion of the basal septum. This is the mid-septum. We can see both the anterior or the inferior depending on how we tilt the transducer. And this is the apical septum. Here we have the lateral wall in the 4-chamber view. Therefore, we have the apical lateral segment here, the mid-lateral segment, and the basal lateral segment. Here is the 2-chamber view. This is the inferior wall. This is the anterior wall. Therefore, this is basal inferior, mid-inferior, and apical inferior. Apical anterior or distal anterior, mid-anterior, and basal anterior. Now let's turn to the 3-chamber view. Here is the posterolateral wall. This is the anterior septum. Therefore, we can divide following segments: basal posterolateral, mid posterolateral, and here we have the distal posterolateral or distal anterolateral segment. Remember, we only have 1 segment. We have fusion of these 2 segments here.
Recording in progress.
The apical septum, only 1 portion or 1 segment of the septum in the apex. The mid septum, which is usually the anterior septum we see here, and the basal, usually the anterior basal septum we see here. I know this all seems pretty complicated, but you can find this diagram also in your fact sheet. And when I show you examples throughout this course, I will repeatedly name the different segments, so you will see eventually it's not that difficult. Another way at looking at the myocardial segments is the so-called bullseye representation. I find this representation actually quite appealing because it gives you a very good overview of the specific segments. Here we are looking at the ventricle from the apex, and we have the myocardium unfolded towards us, and here in the middle we have the apical segments. Those are the mid segments, and here are the basal segments. You can then also see the different regions, the anterior, lateral, posterior, inferior, septal inferior, and septal anterior regions, and thereby describe each individual segment. This plot can then be color encoded for various different things, for example, for the degree of contractile dysfunction, strain, or strain rate. So you'll be seeing this plot very frequently, not only in echocardiography, but also in cardiology in general. I now want to introduce you to another model, which is slightly different from the one I showed you previously, the so-called 17-segment model. The only difference to the previous model is that it has an additional segment here in the apex, the 17th segment, which corresponds to the supraapical region. Why is this model appealing? Because sometimes you have small infarcts which only involve the supraapical region. If you would use the 16-segment model, you would probably overestimate the size of the infarct. By using the 17-segment model, you can clearly demonstrate that only the supraapical region is really involved. For better understanding, here's an example, or two examples actually. A small infarct, supraapical, another patient with a larger apical infarct. If you use the 16-segment model, you could not distinguish the size of the infarct simply by looking at the report or looking at the bullseye plot. For comparative purposes here, an overview of the two different segmental models. The 16-segmental model and the 17-segmental model with the additional segment here in the middle. To give you a better explanation what the segmentation of the myocardium is actually good for, I would like to first explain you or give you a brief overview of the coronary anatomy and start with the left coronary artery. With the left coronary artery, this is the stem or the left main coronary artery, divides itself into the circumflex branch and into the anterior descending branch, also called LAD. The LAD has diagonal branches which are somehow cut off here, which supply the anterior wall and also parts of the lateral wall, and septal branches which supply the anterior septum. The circumflex branch has obtuse marginal branches and the lateral branches, and they supply the lateral wall of the myocardium. The right coronary artery supplies usually this conduction system, the atria, the right ventricle, and has two important branches, the posterior descending branch, which supplies the inferior wall, but also parts of the inferior septum, and the acute marginal branches, which also supply the inferior wall, but also can supply the lateral portions of the myocardium together with the circumflex artery. So how do problems of the various coronary arteries now translate to the...
Now he will describe the coronary supply according to the basics that he explained earlier, and it will be the last part or last 2 minutes or 3 minutes of our talk, of my talk, and then Dr. May will have her addition and comments, inshallah.
The segmental models in echo. First, let's take a look at the four-chamber view. In the four-chamber view, we already said the basal part of the septum is the inferior basal septum, and that is supplied by the right coronary artery. The remaining parts of the septum are usually supplied by the left coronary artery, as well as the apical segments, apicolateral. The lateral segments are supplied by the circumflex artery and also by the LAD, so you will have a mixture of both arteries, the LAD and the circumflex, supplying this region here. If we take a look at the two-chamber view, the LAD supplies the anterior wall and the apex, while the right coronary artery supplies the inferior wall. The inferoapical region can be supplied both by the RCA or the LAD, depending very much on the size of the LAD. If the LAD is very large and if it goes around the apex, you will also have blood supply of the inferoapical segments by the LAD. In the three-chamber view, the anterior septum is definitely supplied by the LAD, and the posterolateral wall is supplied by the circumflex artery, but can also be supplied by the right coronary artery if we have a very large right coronary artery. So this segment can be supplied by RCA and circumflex, And this is usually supplied by the LAD, but can also be supplied by the circumflex artery if it's very large. So you have an overlap in this region here. If we take a look at the short axis view, we have the lateral and the posterolateral walls usually being supplied by the circumflex artery, the inferior and the inferior septum supplied by the right coronary artery, and the anterior septum and the anterior wall supplied by the LAD. But remember, we always have an overlap in these regions, and it depends very much on the degree or the size of the specific coronary arteries, which portions of the myocardium are supplied by which arteries. In the peristernal long axis view, we see the same picture as we see in the apical long axis view. One last thing I would like to emphasize, the right ventricle is mostly supplied by the right coronary artery. So confused? Too much information? Well,
So by this, I will end my talk, and Dr. May.
First of all, thank you very much, Suha, for a very extensive, I don't know how you managed to cover everything in just 1 hour, but you managed to do that. And the two tapes or 2 videos you showed were very good. But let me remind you, before I forget, that the last one for the wall motion abnormality is a little bit older than 2015, because in 2015 there has been upgrade of naming the segments, and I think it's very important that you go over it because the American College of Cardiology has changed things a little bit, and it might be reasonable to go over it. So let me just say my last statement. You as surgeons, you are interested in 3 things that Suha alluded to. Number 1, you are interested in the pre-operative study so that you know what is the abnormality, you know what is the underlying pathology, so you can plan your thing. Luckily, as cardiac surgeons, there isn't much that can be done peri-operatively during the procedure because the patient usually is on pump and the heart is flaccid while the surgeon is operating. But if you help in thoracic surgery where a lot of things are done not on pump but off pump, it is very important, and you will find the anesthetist, especially the anesthetist, keeping an eye on the heart during the procedure. So pre-operatively, not much, but definitely you will be interested in the post-operative because it's going to give you an idea about how good your surgery was, what is missing, did something go wrong last minute, that sort of thing. And 2 of the most common conditions, or 3 of the most common complications that occur as a result of cardiac surgery, unfortunately, Suha did not mention it, but I think they are important, which is the occlusion of the circumflex artery with a big sort of suture, which gives us wall motion abnormality. So it becomes very important that you know wall motion abnormality as a surgeon, in addition to the echocardiographer who's gonna point it out to you. Occlusion of the right coronary artery by aortic valve replacement. It is rarer than the circumflex, but it does happen. And the last thing is after mitral valve prolapse, developing SAM, systolic anterior motion of the mitral valve, and causing more regurgitation than the patient started with. These 3 conditions are very important for surgeons to know about. Otherwise, I have to admit, in real life, surgeons depend a lot on the echocardiography to tell them what they are dealing with. But I think there are very important things every surgeon should know. The anatomy, it is very important. You don't have to go into the unstandard views or anything. You need the basic views. You need to know the role of Doppler in assessing severity of valve disease and severity of stenosis, whether aortic or mitral or pulmonary, and words that are important and that you should be looking into is what is a gradient, what is pressure half time, and what is a continuity equation, what is a PISA to assess mitral regurgitation. You don't have to know how to do it, but you have to know what it is. And the last thing, of course, is wall motion abnormality. You do a lot of cardiac surgery. I don't think anybody sees more horrible vessels than what we see, because everybody takes the good thing and they end up with the difficult cases for King Faisal, and it becomes very important as a surgeon. In addition, watching with the echocardiographer the result of your surgery, whether it is immediate or later as you are seeing the patients in CCU. Again, thank you very much, Suha, for a very nice talk, and thank you for inviting me to join you.
الله يسعدك دكتورة ويعني thank you very much. We appreciate your presence. And it's valuable actually. So Dr. Khalid, do you have any additional things to say or someone to ask Dr. May or me?
السلام عليكم دكتور مي.
أهلين.
أول شيء thank you Suha for your presentation. Dr. May, I just have one question. Which view is the best to document and visualize the pericardial effusion? Is it like the apical fourth chamber, the subxiphoid? I mean, which one is the best?
If you're asking me as a surgeon, I'm gonna tell you all the views, because you are famous to cause what we call localized bleeding, you know, or localized effusions if it is immediately after surgery that are in certain areas. You remember you've just been playing with the pericardium, etc., etc. So you have to look at all the views, because you can miss easily a small pericardial effusion which can be hemodynamically abnormal to the filling of the heart. So unfortunately, you have to look at all the views. Otherwise, a standard view showing you the parasternal long axis, the short axis, and the fourth chamber should be able to show you a pericardial effusion. But please, after surgery, be a little bit with the low sort of, you would like to look more, because you don't want to lose or to miss localized insisted effusions that might interfere with the filling of the RA or the LA. Okay?
Thank you. Yeah, thank you, Dr. May.
So any other question to Dr. May?
شكرا الله يعطيك العافية دكتورة.
Thank
you,
you.
Dr. May, for joining us today, and thank you, Suha, for your presentation. We'll be grateful, Dr. May, if your valuable time allows you to join us with our last lecture. Will be a short talk on role of stress echo in cardiac surgery. We'll start in 5 minutes.
That. It's okay. I will do that. Thank you.
Thank you so much, Dr. May. So we'll have a 5 minutes break, and then we'll come back at 3:10 to resume our last lecture for today.
Assalamu alaikum. Good afternoon, everyone. This is Al-Anud Al-Mhaysin, and today, inshallah, I will talk about the role of stress echo. So by the end of this presentation, we will talk about the definition and important role of stress echo. We will identify the indication and contraindication. We will describe the technique and how to perform a stress echo. We will review the clinical relevance of stress echocardiography. So stress echocardiography constitutes the combination of two-dimensional echocardiography with physical, pharmacological, or less commonly the electrical basing. In some patients, stress may increase ischemia or lead to a new or worse wall motion abnormalities. Stress echocardiography plays an important role in identifying wall motion abnormalities in the assessment of ischemic heart disease, plays a vital role in the evaluation of systolic or diastolic heart failure. In case of valvular pathologies, non-ischemic cardiomyopathy, pulmonary hypertension, and congenital heart diseases. Indication for performing a stress echocardiography include coronary artery disease or diagnosis of coronary artery disease to assess adequacy before and after revascularization, risk stratification in known cardiac coronary disease, identifying the location of ischemia, in case of preoperative risk assessment for evaluation of cardiac etiology of exertional dyspnea to assess valvular disease, and in case of left bundle branch block. The contraindication for exercise or pharmacologic stress echocardiography, we can divide them into absolute and relative contraindication. Here with the absolute, we will have the acute myocardial infarction within 48 hours, acute pericarditis, myocarditis, symptomatic severe aortic stenosis, uncontrolled arrhythmia causing symptoms or instability to the patient, acute aortic dissection, high-risk unstable angina, decompensated or unstable heart failure with left ventricular ejection fraction of less than 35%, acute pulmonary embolism or pulmonary infarction. The relative contraindication include left main coronary artery stenosis, high-degree AV block, severe hypertension, electrolyte abnormalities, mental or physical disabilities, tachycardia or bradyarrhythmia, moderate stenotic valvular heart disease. So now we will talk about the technical equipment that we will need them for performing a stress echocardiography, which will include ultrasound machine, probes, either 3.5 or 5 megahertz, the digital image acquisitioning system, blood pressure cuff and stethoscope. We will need EchoBets workstation and chairs for the sonographer, contrast agitator machine, and contrast for border delineation, emergency equipments, which include a portable defibrillator, oxygen mask, bag mask valve resuscitator, intubation equipments, code cards, suction apparatus, syringe, needle, and intravenous tubing. So stress echocardiography equipment takes into consideration the M mode, two-dimensional, color, and spectral, both flow and tissue Doppler imaging that Dr. Soha mentioned earlier, for evaluation of ischemic heart disease. Contrast agents are used as indicated for patients in whom at least two endocardial wall territories are not well visualized. So when we perform stress echo, it's important to identify the anatomy and studying the various wall motion abnormalities and understand the vascular territories associated with the various segments. So the segments are studied in 6 views: the parasternal long axis, the parasternal short axis view at the level of mitral valve, papillary muscle, and the apex, apical 4-chamber view, and apical 2-chamber view. So this picture describes the views that we mentioned, and Dr. Soha prescribed them earlier. We will have the parasternal long axis view, parasternal short axis view, and the apical 4-chamber. We will also have the apical 2 chambers. So the parasternal long axis view, the segment we can see here in the picture on the right, we will have the left atrium, mitral valve, LV, aortic valve, and aorta. Here we will have the right ventricular outflow tract and the interventricular septum. So the segments seen in parasternal long axis are the basal anterior septal and mid anterior septal on the septum, which are supplied by the LAD, basal inferior lateral and mid inferior lateral, which will be supplied by right coronary or left circumflex artery. In this picture, we can see the long axis view with normal LV function. We will observe the wall thickening, the wall motion, and the opening of mitral valve leaflets. Here we will have the left atrium, mitral valve, left ventricle, and RVOT. We will observe the inward and outward exclusion of the wall. Here we can see in a patient who is having a moderately reduced LV function. We will observe also the wall thickness and wall motion and the opening of mitral valve. The last one in this view will be severely reduced LV function, as we can see here in the wall motion. The second view, which is the parasternal short axis view, we will have 3 levels at this view. Segments are seen in parasternal short axis view are the mid anterior septal and mid anterior supplied by the LAD, mid inferior septal, which is supplied by the right coronary artery, mid anterior lateral and mid inferior lateral, which will be supplied by left circumflex. And we also will have the mid inferior, which will be supplied by right coronary artery. Here at the right side, we will have the papillary muscle level. We will see the LV and RV and both anterolateral papillary muscle and posterior medial papillary muscle. Here we will have the aortic valve level. As we can see here, we will have the LA, RA, RV, both pulmonary valve and a tricuspid valve and aortic valve. The last view in short axis, the last level, in short axis view, which will be the mitral valve level. Third one is the apical 4-chamber view. As we can see, we can observe the 4 chambers of the heart with the valves, mitral and tricuspid valve. The apical cap will be supplied by the LAD and left circumflex artery. The apical septum and mid inferior septal will be supplied by the LAD also. The basal inferior septal will be supplied by right coronary artery. Apical lateral and mid anterior lateral, basal anterior lateral will be supplied by left circumflex artery. Here we will have the apical 2-chamber, which will show the left atrium and left ventricle with a mitral valve. Segments seen in this 2-chamber view will be the basal inferior and mid inferior supplied by the right coronary artery. Apical anterior supplied by right coronary artery or LAD. Apical inferior, basal anterior, and mid anterior, which will be supplied by LAD also. So when we assess the wall motion with 2-dimensional echo, we will give a score for this wall motion. 1 means that there is a normal or hyperkinesis. 2 means that we will have a hypokinesis. 3 means akinesis or severe hypokinesis less than 10% of systolic thickening. 4 mean dyskinesis, which will mean we have a paradoxical systolic motion. 5th will be aneurysmal, there will be a diastolic deformation. So now we talked about the echo, now we will talk about the stress testing method. We will use 2 methods, exercise stress testing or pharmacological stress testing. Starting with the exercise, we have 2, the treadmill and the bicycle. Treadmill stress echocardiography, we will use Bruce protocol, most commonly used for treadmill exercise echocardiography. Exercise capacity is reported in terms of estimated metabolic equivalent of task. Imaging studied are before at rest, immediately after completion of the exercise, and compared for evaluation of wall motion abnormalities. Bicycle stress echocardiography, less often used than treadmill, can be performed using supine or upright bicycle ergometry. Usually bicycle protocols start at workload of 25 watts and increased by 25 watts in increments every 3 minutes until an endpoint is achieved. Permits sensitive pericardial measurement without much motion artifact. Bicycle exercise usually offer a Doppler information in addition to assessment of regional wall abnormalities. Now we will come to the pharmacologic stress testing. We will start with the dobutamine echocardiography, a graded dobutamine infusion starting from 5 microgram per kg per minute and increasing at 3 minutes interval to 10, 20, 30, 40 microgram per kg per minute is a standard for dobutamine stress testing. The importance of low dose stages play a role in recognition of viability and ischemia in segments with abnormal function at rest. Endpoints are the achievement of a targeted heart rate, which is 85% of the age-predicted maximum heart rate. To achieve a target heart rate, atropine can be used in divided dose 0.25 milligram, 2.5 milligram to total of 2 milligram, because atropine will increase the sensitivity of dobutamine echocardiography in patients receiving beta blocker and those with a single vessel disease. The second one from the pharmacologic stress testing, it's a vasodilator. We have adenosine and dipyridamole can be used in stress echocardiography. Dipyridamole will be administered up to 0.84 milligram per kg in 2 separate infusions, 0.56 milligram per kg over 4 minutes, followed by 4 minutes of no dose. And if an adequate physiologic response is not achieved, we will add 0.28 milligram per kg over 2 minutes. Atropine is used also to enhance test sensitivity, in addition to a hand grip at peak infusion may enhance the sensitivity. The duration of action of adenosine will be shorter than dipyridamole. Adenosine stress is used to assess myocardial perfusion with contrast echocardiography, but has not been widely used as a clinical tool. The last one in pharmacologic stress testing will be pacing stress testing. This will be indicated in patients with permanent pacemaker and who are not able to exercise. Targeted heart rate to be achieved by increasing the pacing. The pacing protocol consists of 2 minute stage and an increasing paced heart to level of 85% and 100%, respectively, for pre-peak and peak stress information. Termination of stress test occur with achievement of age-predicted maximum heart rate, new or worsening moderate regional wall motion abnormalities, greater than 2 millimeter horizontal or downsloping of ST depression, or presence of intolerable symptoms. In this case, we will stop the test. So the interpretation of stress echo depend on obtaining the image at rest and stress and comparing the LV size, shape, and function. In patients with multiple vessel disease, exercise echocardiography will demonstrate a dilated LV cavity with change in the shape and reduction of systolic wall thickening of the septum, anterior and inferior walls. Prolonged systolic wall thickening may also indicate a severe coronary artery disease. So the coronary arteriographic cutoff of luminal diameter stenosis at which wall thickening abnormalities will occur, it's 54 in case of with the exercise, 58 for dobutamine, and 60 for dipyridamole. The sensitivity for the detection of coronary disease are 85, 80, 78%, with the specificities of 77, 86, and 91% for exercise, dobutamine, and dipyridamole stress result. However, diagnostic accuracy varies according to the likelihood in coronary artery disease in patients who we are performing this test on. So this schedule will summarize everything regarding the stress echocardiography, regarding the interpretation, I mean. So it will compare between the normal response and the ischemic response. In case of treadmill, spine, bicycle, dobutamine, vasodilator, and atrial pacing. So in case of treadmill, we will have normal response is the hyperkinesis post-exercise compared to rest. The ischemic response will be hypokinesis compared to rest. The global response, there will be increase in normal, there will be increase in end-diastolic volume, decrease in systolic volume, and increase in ejection fraction. In case of ischemic response, we will have increase in end-diastolic volume, increase in end-systolic volume also, and there will be a decrease in ejection fraction in the left main and multivessel in case of multivessel disease. In the supine, it will be the same, hyperkinesis in normal and will be hypokinesis in ischemic response. In dobutamine, there will be marked hyperkinesis, increased velocity of contraction compared to rest and at low dose. In ischemic response, we will have a hyperkinesis, decreased velocity of contraction compared to low dose and usually compared to rest. And vasodilator also will have hyperkinesis as a normal response. Ischemic response will be hyperkinesis. The same will be in case of atrial pacing. So the clinical significance of stress echo, it has an advantage in terms of specificity over standard exercise electrocardiography. When compared to nuclear perfusion imaging studies, stress echocardiography has a similar accuracy with a moderate sensitivity gap that is well balanced by a higher specificity. Both dipyridamole and dobutamine have an overall good tolerance and feasibility. The choice of one test over the other depends on the patient clinical characteristic and the physician preference. Diagnostic accuracy can significantly be affected by anti-anginal medical therapy, particularly beta blocker, and therefore it's recommended to withhold medical therapy at the time of testing to avoid a false negative results. Lastly, we'll talk about the complication that may occur with stress echocardiography. In case of dobutamine, the most common cardiovascular side effect associated with dobutamine are angina, hypertension, cardiac arrhythmia, atrial fibrillation, non-sustained ventricular arrhythmia, which occur about 3% of the patient. And we will have sustained ventricular tachycardia. It's not common. Dobutamine can also induce a left ventricular mid-cavity and outflow tract obstruction, and it may lead to frequent premature atrial or ventricular contraction in about 10% of the patient. In case of vasodilator stress echocardiography, the major adverse effect is myocardial infarction, asystole, and ventricular tachycardia, hypertension, bradycardia that may occur but can be treated with aminophylline. Basing stress echocardiography can lead to a Twink-Bach second-degree heart block. It will require atropine administration. This will be the last slide in my presentation. Thank you so much for your listening. If you have any question, you are more than welcome. Thank you.
This is Dr. Shahid. Can I comment?
Yes, of course, doctor.
First of all, thank you very much for a very, very concise and to the point presentation. It is really nice. Second, I would like to thank you because you have used the new segment names. As you must have noticed, all of you, that the word posterior is no more used, and instead of it, we're using inferolateral. So for you who are interested in the names of the segments, you might refer to that rather than the talk of the people from Netherlands, because it's a bit, they're still using it, by the way, but we have to follow the American guidelines, and these are the American guidelines. The second thing is it's very important when we assess wall motion for abnormality to look at two things, not only the contraction, which we call it the mobility of the wall or the motion of the wall. We have to look at thickening in systole. This is very important. A lot of people don't pay attention. We have to look at two things, the motion, which is the contraction, and the thickening in systole. The third thing I would like to mention that you said symptomatic aortic stenosis is a contraindication. I agree with you very much, and we have to underline and highlight the word symptomatic, because many times we examine part of our assessment of aortic stenosis and impaired left ventricular function is to do exercise tests for asymptomatic patients. But again, we have to document that very carefully in the notes that the patient has denied symptoms so that you expect to have problems and they are hiding the symptoms about it. And the last thing is treadmill versus bicycle. Bicycle, unfortunately, is not very familiar to the females of our culture who are older. And sometimes it is very difficult to even convince them to raise their legs and start moving with the bicycle. And it is good, by the way, because it allows you to document things without fear. Remember, when we do treadmill, we have to have the patient on the bed after the end of exercise, and we have to get all of our views within a minute, a maximum of 1 minute, maybe 10 seconds, so that we get the necessary information. And this is sometimes very difficult to do. Bicycle, you can continue recording by echo, whatever you want to record with no problem, although treadmill is more physiological, more reflection of what really happens. And let me have one last comment. What is real life? Real life, our patients, whether males or females, are fat. They lack the basic things about walking, knowledge of walking on a treadmill. They move with difficulty, so it becomes very difficult to get them from the treadmill to the bed to get the necessary views. And again, females are not very friendly with a bicycle. So in short, we do exercise tests, not for ischemia, we do it for valve disease. But when it comes to ischemia, obese, older, etc., they don't cooperate, and we end up not getting the information we do. So I don't know if those of you who rotated with us, we rarely do exercise stress tests the way Dr. Al-Anud described it. We prefer to use dobutamine when the need really arises. And now, of course, we have MRI to give us a lot of the information that we were getting otherwise. Again, Al-Anud, thank you very much for your talk.
Thank you so much, Doctor, for the valuable information. Thank you.
Dr. May, this is Ayat. Dr. symptomatic AS, you were mentioning that contraindication. So we don't take them even if they are asymptomatic, right? Because they are having a severe AS. So how come we are going to stress them more?
I'll tell you why. And that's why I'm going to stress on one thing. A Baba comes to you and بيحلف بالله وبالقرآن إنه he is asymptomatic. And his valve area is 0.7. How can you convince such a person that you need surgery? Number one, you have to document that he denied symptoms. And then you, as a doctor, do the exercise. You don't leave it for a junior or for a technologist. And you start with the lowest. We don't do a Bruce protocol, which is a hard one. We start with a modified Bruce protocol. I've never seen anybody walking more than 1 minute or 1.5 minutes, because you know an area is 0.7. There's no way they can be asymptomatic. So it is, you are there, you are stopping the exercise. We not only look for symptoms, we do blood pressure every minute. We don't only look for symptoms, we look at response of blood pressure. At any hint that doesn't make, for example, if the blood pressure does not go up, stop the exercise even if the patient denies symptoms, because they might either end up having a syncope or even dying on you when they have severe aortic stenosis. So it is not an easy thing. To protect yourself, you clearly document what the patient says, and then you do it very carefully. You start low, don't start with a very hard exercise test. Watch them very carefully for blood pressure every minute. And then if you see anything that you're not happy, immediately stop the exercise. I hope this Ayat answers your question.
Yeah, I was like thinking about the idea that the severe AS is dangerous to be severe AS patients. I think it's dangerous to get them stressed more and more. This is this was my question. But
you start gently, and believe me, they will they will act exactly as you expect them to act.
Yeah.
They don't go on, and that's it.
Yeah. Okay. Thank you.
Dr. May, Assalamu alaikum.
Alaikum assalam.
My name is Faisal Ghamdi. I have another question regarding stress testing in AS patients.
Okay.
We had one patient who presented to our hospital with exertional shortness of breath and chest pain. And the first workup we did for him was echo. And the echo transthoracic showed that his ejection fraction is 30. And the aortic valve area was around 1.5. And the gradient is 30.
Okay.
And his coronary arteries were normal. Is this a patient who's fit for stress testing?
Okay, Faisal. I think the first question that you want to answer before you even think of exercise is why is his gradient is only 30. Okay, you have to ask yourself this question, and why is the gradient only 30 and he has severe AS? And there are a lot of things that before you reach the decision about exercise that you have to consider. Classically, you said the area was 1.5. Am I right?
Yes, Doctor.
1.5, first of all, as an area is not severe AS. Okay, so you don't, severe AS is 1 and index to 0.7 or 0.6. So this patient does not have severe AS. Now you could ask yourself, okay, the ejection fraction is impaired. The ejection fraction itself with the heart not contracting, even if the stenosis is more severe than 1.5, it's gonna give me a low gradient. The heart is not going to push enough to give me a gradient. So this is what we call low gradient, okay? Low gradient 30. Impaired left ventricular function if the function is impaired, okay? And low gradient severe AS, which your patient does not have. These are the ones. So there is 3 things. First of all, it is severe AS. It is low gradient in presence of severe AS by area. And these are the ones that we do for them the dobutamine echo. Am I so far along what you're asking about? Because I'm going to speak more about it. Because, yes.
Dr. May, how did you say he is severe until now?
Your patient is not severe. Your patient is not severe. But what we're speaking about exercise, she mentioned pharmacological al-anud. So this is dobutamine. So if I have a patient who has severe AS by area, but the gradient is low, I look at the ventricle, okay? If the ventricle is impaired, a low gradient is expected with the impaired left ventricle because the ventricle is not contracting. And these are the patients where we have to ask ourselves the question, is the impairment of the left ventricle secondary to the severe AS, or is it a myopathy? Because if it is secondary to the AS, then if I operate and give him a normal valve, the ventricle will go back to normal. No matter how severely, the majority will go back to normal. But if it is myopathic, then even if maybe the valve is not opening, it is not severe, but it's not opening because the ventricle is not contracting enough. And then if I send these to surgery, I might kill them because the valve is stenotic. So I do a dobutamine echo. What does the dobutamine do? It makes the ventricle contract better, isn't it? It's an inotropic drug. So if he has true stenosis, true severe stenosis, the ventricle will start to contract better, the gradient will increase, but the area will not change. Are you following me so far?
Yes.
But if he has a myopathy, I treat impaired left ventricle with dobutamine to improve the cardiac output, isn't it? So when I give the myopathic patient dobutamine, the contraction will be a little better with the dobutamine. This is enough to open the valve, which is not stenotic, but not opening because of the impairment function. So I divide then my impairment of the left ventricle into two categories: that which will not change the mitral valve area when the ventricle contracts better, and that will increase the aortic valve area when the ventricle contracts without increasing the gradient. So I operate on the first one, I don't operate on the second one. So yes, exercise test in this condition is important with dobutamine to differentiate these two categories. Not to confuse you, but because to put you on what is happening around us. We used to love aortic stenosis. You get a small area, a large gradient, and that's the end of it. Now there are 5 categories. So I mentioned the impaired left ventricle with the low gradient and severe AS. We have patients who have severe AS, low gradient, but normal left ventricle. Normal left ventricle. So you would expect it to give you a high gradient, but it does not. These patients are called the paradoxical ones. What happens is that they have hypertrophy of the left ventricle. And as a result, the cavity of the heart is very small. So they don't fill it. They don't have any, it does not take a lot of blood to fill because of the hypertrophy. So they don't push out blood into the aorta to give me a gradient. So this is another group of patients. They have normal left ventricle, but hypertrophied. Usually they are females, hypertrophied, hypertensive. So now we speak not only of the area, not only of the gradient, we also speak about the left ventricular function. And to add مصايب أكتر علينا, you know, to make it even more difficult, now we speak of flow rate across the valve. So aortic stenosis has become such a difficult thing to assess when things do not add. Your patient has an area of 1.5, which makes him not stenotic. So I wouldn't expect him to have a high gradient. And to have a gradient of 30 is reasonable. This is a sclerotic rather than a stenotic valve. Does this confuse you?
No, actually, it's clear now, Doctora. But if I do stress echo, stress test, and the gradient goes to 30, he's now labeled as severe AS patient, right?
No. If you do an exercise test for this patient, he's gonna improve his function. I don't know, did you tell me his ejection fraction is 30? So if you do a dobutamine, are you speaking about stress echo or stress or dobutamine echo?
Dobutamine stress echo.
Okay, if you do a dobutamine, this patient, which we think so far is not severe AS, he's gonna improve his contraction. So the 30 will become 40. And as a result, the contraction of the left ventricle is most probably is gonna open more the aortic valve because we don't think it is stenotic. So if it opens more, the gradient will not go up. It will go up a little bit, but not significantly. But if the gradient goes up and the area remains as is, then you have to ask yourself, is the area that I measured initially is true or not? There is a lot of things that can go wrong with this measurement.
I understand.
And again, remember, hypertension. If you do such an exercise test with hypertension, the hypertension, I'm gonna have higher blood pressure in the aorta. So the difference between the aorta and the LV will be less. And again, this could be a reason why the gradient is low. So ask yourself, did I do the study well? That's number one. So technique-wise, it has to be done well. If you are happy with the technique, then you have a lot of other things to Answer. Do you know reporting an aortic stenosis? Reporting, not doing. We report an aortic stenosis not in less than at least 40 minutes, believe me. Because we have to look at everything. We have to look at the technique. We have to look at the measurements. Everything depends on proper measurements. And as a result, I have to repeat it if the hypertension is high. I have to look at the left ventricle. Is it hypertrophied? I have to look at the stroke volume. Is it a volume that is enough, or is it a small volume because the left ventricle is hypertrophied? I hate reporting at the end of the day on aortic stenosis. I hope I answered you, Faisal.
Yes, you answered me. Thank you, Doctor. Last question. The paradoxical aortic stenosis, I have heard this term once.
Okay.
But it did not make sense to me. But now after you explain, it does make more sense. But how do you diagnose it?
We diagnose it by getting initially a good area that is done properly, which is small. So this person is labeled as severe AS, depending on a good measurement of the area. Next, I look at the gradient, because this is very important. The gradient will be low. That's why it's called paradoxical, in addition to the left ventricle. But let's take it step by step. I look at the area, it is small. I look at the gradient, it is again small. First thing, check on the blood pressure. If the blood pressure is okay, you go further. You look at the wall of the left ventricle. Is it hypertrophied? Is it a female above 70? Is the cavity small? So if the cavity is small and the left ventricle is hypertrophied, I know I'm dealing with the paradoxical thing. And if the function of the ventricle is normal, okay, then I'm dealing with the paradoxical. Paradoxical in the sense that a low gradient should have an impaired left ventricle, but this ventricle is normal. And the reason is because of the hypertrophy and the small size of the left ventricle cavity, they are not filling. So they don't have much blood to go through the aorta to give me a gradient. I hope this again makes it clearer for you.
It is clear. I'm really sorry, Doctor. One last question. When do you index the aortic valve area?
You have to index it always. And the good thing, actually, it should be routine. But when you are dealing with the extremes, okay, if it's a very big person, okay, this becomes very important. We have a friend of ours called Dr. Admawi. Every one of us compare ourselves to him. MashaAllah Ali, Allah yahfaظه. He's a tall person, big person. We are small. We always say, compared to Dr. Admawi, my requirement is different. So you index at the extremes. You index females who are small, and you index everybody who is big. Because frankly, you should index everybody, but definitely these two extremes have to be indexed. Because the requirement of somebody who is tall and big is going to be completely different from somebody who is small. So this is what sometimes we refer to when it happens, especially in the aortic valve, as patient prosthesis mismatch. You get different gradients across the valve prosthesis, of course, but all valve areas have to be indexed.
Clear, Doctor. Thank you.
Ahli. Okay, then.
Any other question or comment from the group?
Can I ask one more question, Doctor?
Okay, I'm gonna start charging you. Go ahead. Go ahead.
One thing I think is important for preoperative planning is to measure the aortic root or the aortic valve annulus. Where is the best place to measure it in order to at least estimate the valve size?
If you forget I am an echo person, the best measurement for aortic root, frankly, or the annulus for the sizing is a CT scan. Okay, let's not deny that. But when we measure ourselves by echo, remember the mitral valve has an annulus. It is anatomically there, right? There is fibrous tissue that's in that area. So a mitral annulus is really true annulus. The aortic valve does not have an annulus. It does not have an anatomical annulus that contains fibrous tissue, etc., etc. But people have started to refer to the annulus of the aortic valve where the leaflets are inserted. So we do our measurement at the insertion of the leaflets, okay? In mid-systole, the valve has to be almost open till mid-systole, and we do our measurement. Sometimes we have so much calcium in that area that I cannot do a proper measurement. I'm not happy. So we have been allowed since the last guidelines by the European and again the American to measure at least 0.5 to 1 centimeter under what I call as the annulus, which is where the leaflets are attached. Okay, so we go down into the LVOT. So one end of my measurement is the interventricular septum. My other end of the measurement is the anterior mitral leaflet. So now we are allowed to do this measurement around 1 centimeter below the difficult to measure insertion of the leaflets.
Clear, Doctora. Thank you very much.
Ahlin. Please, let's end it before Faisal asks another question.
Okay, thank you, Dr. May, for joining us today and for your valuable contribution in our academic meeting for today. And thank you, Nanood, for your presentation. And thank you, everyone. We'll see you next week, inshallah.
Inshallah. Have a nice weekend.
Thank you, Dr. May.